Thank you for listening to the Bladder Battle Podcast, special series, I See in the Dark. This series dives deep into the perplexing disease, interstitial cystitis. This podcast is intended to bring awareness and create conversation around the illness by providing possible remedies, tips for managing the disease, how you can show support, and so much more. This podcast is not intended to be a medical alternative for physician care, nor to treat, cure, or prevent any illness or disease. Always consult with a physician for professional medical advice. Today, we are getting an official definition of what interstitial cystitis is from a urogynecologist. And we are going to dive into some of the possible treatments that are available to help those living with IC. So I want to welcome Dr. Barenberg to the show. Thank you so much for joining me today.
Absolutely. Thanks for having me on.
Yeah, so this is going to be a great episode. I'm so happy that you agreed to be on. So before we kind of get into what a urogynecologist is and how that can, possibly help someone with IC, why don't you give our audience a little bit of background about you and why you decided to pursue a career as a urogynecologist?
Sure. So I'm currently located in Oklahoma City, Oklahoma. I've lived all over the country from Florida to Texas to Chicago, and landed here, met my wife, and here we are. A little bit about kind of my journey to urogynecology. I come from a long family history of physicians. My grandfather and my father were both internal medicine doctors. My dad's a GI doctor. And so when I went into med school, I thought I was just going to kind of follow what they did and end up doing gastroenterology. What I realized shortly was that there was way too much thinking and not enough doing for me. I like to work with my hands. I like the surgical side of things. And so I kind of went down that path. And of course, there's a ton of different surgical subspecialties to choose from. And then at that point, it really just kind of came down to finding the personalities that seemed to fit mine. And oddly enough, and I was never guessing this would happen, that it happened to be in OBGYN. And, I'm very much so, people would have described me in college as being like a bro. And so it was a lot of people kind of were like, wait, you're going to do what? But it worked. It worked for me. I really enjoyed the patient population. And I really enjoyed the surgeries because they were complex. And by that, I mean, I like to kind of describe it as people who fly airplanes. If the weather's bad, you have to fly by instruments. You can't really see what you're doing. And so in vaginal surgery and a lot of things that I do in pelvic reconstructive surgery, you can't see what you're doing. You have to know where you are. You have to be able to see things in 3 dimensions in your head and be able to feel where you are in the anatomy. And that was really, really challenging. And so that really drew me towards the field a lot more than the obstetric side, although I did enjoy that briefly while I did my residency. And then I did my medical school at the University of Texas and then my residency at Loyola University in Chicago. And at that time, some of the real big influencers in the urogyne field were based out of my institution. And I just kind of went under their wing and just tried to soak up as much as I can and learned a ton. And they kind of fostered my interest and helped me match fellowship. And then now here we are. So it's been a long road, but it was exactly what I anticipated it to be. And on the back end, I still enjoy taking care of my patients and doing the surgeries and talking on podcasts.
Wow. Well, that is quite the story. Very interesting background and kind of how you got to where you are. So for our audience that doesn't know, what is the difference between a urogynecologist and a urologist?
Sure. So we can look at it from the urology side first. So urologists focus on the urinary tract in men and women. They focus on the urinary tract, everything from the kidney and the adrenal glands, which help with our hormones and stress response, down through the ureters, which are the kidney tubes. They go from the kidney to the bladder, and then they do the bladder work and everything that comes out of the bladder. So for women, that includes things like chronic urinary tract infections, a lot of kidney stone type disease, things of that nature. And in men, it's a lot of prostate. So prostate issues, prostate cancer, kidney cancers, adrenal cancers. So they tend, from my experience, tend to be more focused on the cancer side of things than lower urinary tract, pelvic side of things. So urogynecology subspecialty, you can get there either through urology training residency or obstetrics training residency. The big differentiator is that a urogynecologist is pretty much focused on the female pelvic floor. That includes the pelvic floor muscles, includes the bladder, it includes all the uterus and the vagina and all the rectum, everything that has to do with the structure, support, and function of those organs. So we don't focus on kidney stones. Some urogynes do if they have a urology background. I don't focus on kidney stuff. I'll usually send that off to a urologist, but I do a lot of the functional medicine. So constipation issues, functional bowel disorders, functional bladder disorders like interstitial cystitis. And then primarily our bread and butter is prolapse and incontinence stuff. So, and post-birth trauma.
Gotcha. Yeah, that was kind of my initial understanding of what a urogyn was, because when I started going through this process, someone had mentioned that I should check that out. And when I Googled it, that was the first thing that came up, was like prolapse. And I'm like, I don't have that issue. So that's a great way to really define it and describe it. And there's a lot more that goes into it. Now, pelvic floor dysfunction and interstitial cystitis are, typically go hand in hand as well. So it's great to sort of have that other background with gynecology so that you can really help those patients suffering through this to kind of relieve those painful symptoms.
Right.
Yeah. So can you give us an official definition of what interstitial cystitis is?
Yeah. So my definition, I try to just keep things simple. It's this perceived feeling of discomfort, pain, pressure, urgency, frequency. In reality, any symptom that you would have of a urinary tract infection could mimic interstitial cystitis. And the typical story is that you have these symptoms for more than 6 weeks. And a lot of times I have patients that come in that say, I keep going to the doctor, they keep culturing my urine, they keep throwing antibiotics at me, and I'm still infected. And so that's the first trigger. So it's probably not infection, it's inflammation. So that's the big differentiator. We're not trying to kill a bacteria here, because that's not the root of the problem.
Right.
We're trying to focus on the inflammatory condition of the bladder lining so that we can essentially cool it off, so that those same symptoms that come with urinary tract infection, because bacteria is inflammatory, we can get rid of that without throwing people on all kinds of antibiotics and really focusing on the inflammation of the bladder wall.
Right. Because if you start to take antibiotics for everything, that can really screw up your gut. That can lead to other issues. And that's definitely the treatment that I went through for about 4 years before I finally was fed up and decided there has to be something else going on. I'm not getting chronic UTIs.
Right.
So what are some of the kind of pain areas that one might feel?
Sure. So there's multiple phenotypes or ways that it can present. Majority of the time, the story that I hear is A, the recurrent urinary tract infection deal. And then B, I hear a lot of times when my bladder is full, is really painful. And when I void, I have brief relief and things improve some, but then I'm right back in the bathroom doing that again. So we get people that will have, the bladder fullness and pain that comes with their bladder being full. You'll also get people that have burning in the urethra, or the exit from the bladder to the outside world, where they just can't get that to go away. It's always kind of nagging at them. And a lot of times doctors that don't do a lot with interstitial cystitis will pick that up as, oh, well, you probably have vaginal atrophy, lack of estrogen. Oh. That doesn't make sense to somebody who's under 50, right? They're not going through menopause. So throwing them on estrogen probably won't help. And by the time they get to me, they've already tried all these things. Other things we tend to see that run in conjunction from the bladder root. So if you have an inflamed bladder, then all the organs that surround the bladder in pelvic floor case, the pelvic floor muscles get inflamed and irritated. And when that happens, those muscles can go into spasm. And so you get what's called levator spasm or pelvic floor spasm. The way I like to describe that is if I take a knife and I stab somebody in the arm, they say, ow, and they look at me crazy. And then if I try to stab them again, they contract their arm, they pull it away from me, right? They're trying to protect the organ. And so your pelvic floor will do the same thing. Your bladder hurts, ow, okay, well, what do I do now? Well, let me contract and try to protect it from whatever's causing the dysfunction or the pain. And unfortunately, our bodies are smart, but unfortunately, that leads to more discomfort because it becomes this chronic cycle of inflammation of the bladder and then inflammation of the muscle. And if you don't kind of take it all together, you're going to miss a piece and it's never really going to go away completely. Other things that patients tend to describe, sometimes they'll actually see blood in their urine just randomly, or if they're having a flare where, hey, I swear to God, I have a urinary tract infection. I actually have blood in my urine this time. But when they cultured it again, it was negative, right? So it's a spitting image of a UTI. It's just there's no bug. Other things people will say, when they start to get to pelvic floor dysfunction, you start to see things like constipation rear its head, where the pelvic floor is so tight, people can't empty their bowels. It can interrupt your voiding pattern. So you can become incontinent because you feel like you're constantly running to the bathroom, or it can start to instigate bladder spasms that you can't control, and you just get these random leaks throughout the day. There's so many different ways that it can present. That's what makes it so tough. And that's also the reason why your experience when you said, the doctor was like, well, you don't have anything, so it must be IC. That goes back to the way we were taught in med school and residency and whatnot, that it's a diagnosis of exclusion. So you have to rule out all those things. And then when nothing else is there, a lot of times when people just chalk it up to IC, the downside of that is physicians that don't focus on IC, they don't really know where to go from there.
Just feels like there's not a lot of information or not a lot of doctors out there that are willing to understand it or really kind of dive deep into it so that they can help their patients. Now, I kind of want to ask you, I don't know if you've seen this with any of your patients, but a few people that I know that have this condition and myself experience kind of a weird pain in our hip area where there's muscle spasms. Would that have anything to do with IC? Because it seems to be kind of a correlation between myself and the people that I know that have it.
Yeah, 100%. I would say 100%. So if you think about the muscles of the hip, pelvic floor, lower abdomen, lower back, they all insert somewhere in the pelvis, and especially certain muscles that run through your hip socket and insert there to help you rotate your hips inwards and outwards. You can definitely get irritation in those muscles that start to spasm. So I think that would be not uncommon.
Gotcha. Everyone experiences this illness in such a different form. So it's really hard to sort of get support from one another because it's not a very classic disease, unfortunately.
Right.
So if somebody is experiencing all of this, how do you go about diagnosing them? Is there specific testing? Is there any procedures that they need to go through? And kind of what are some of the viable treatments out there?
Sure. So the testing part of this is also tricky and obscure. Usually what ends up happening, first and foremost, people most of the time go to their primary care doctor because they think they have an infection. The things that will happen there, or they'll go to the OBGYN and they'll do a pelvic exam and they'll take a catheterized urine specimen and say, oh, there's blood or white blood cells or what have you in the urine, and they'll throw you on antibiotics and send you out the door. Which I can't fault them for that, because common things being common, that would be the most common thing to happen. Then what happens is the patient comes back with the same symptoms, like you did for, what would you say, 4 years, before you figured,
Right.
you probably got frustrated that it wasn't going away, and sought your own mechanism to figure out what was going on because it just didn't add up.
Oh, yeah.
And so that's usually by the time, as a Uro guy, and that's when I get them, right?
Mm-hmm.
And so my initial assessment is pretty similar. I'll do a pelvic exam, but the key here is the history. So the more information you can provide to the provider about your symptoms, is it better when I void? Is it not better when I void? Does it burn in my urethra, or is it this deep kind of bladder radiating pain that it's hard to describe? Is it painful for intercourse? Is that pain at the opening during intercourse, or is it pain deep? Do I feel like it's if something hits my cervix, that's where my pain is? Or is it certain positions that where my bladder is taking, the pressure? All those things are helpful to help guide the provider to make the appropriate diagnosis. And then during my physical exam, we do things a little bit differently. So I like to rule out all of the other potential physical causes that could be happening. So typical heart, lung exam, that kind of stuff. But on the abdominal exam, I try to rule out abdominal spasm by doing certain maneuvers that can essentially separate deep tissue from superficial tissue, like the muscles in your abdomen. And many times people will have a little bit of spasm there, and a lot of times it's right over their bladder. But then, so if I make you make your abdomen rigid, like you put your chin to your chest, or if you do a leg lift, both legs at the same time, that isolates your abdominal muscles. So if I push on you, then you're like, nope, that doesn't hurt. But then you relax and I push deep and you're saying, oh yeah, that hurts really bad. That's a clue, something deeper, right?
Huh, that's interesting.
And then on the pelvic exam, we look for common things. Depending on the patient's age, we look for things like vaginal atrophy or lack of estrogen that would maybe be causing burning. We look for trauma, like if somebody had surgery or had mesh placed or things like that, just to rule out all those things. But the key on exam for me, first and foremost, is when I do a digital exam, if I push up on the bladder and you jump off the table, that's a pretty good sign that it's coming from your bladder, right? And then what I'll do is I'll reflect that, and then I'll push down on the pelvic floor to see if that's tender. Majority of the time, from my experience, the bladder seems to be a little bit more tender than the pelvic floor, but the pelvic floor is tender as well. So they kind of go hand in hand. And then at the end of my exam, I tend to take a catheterized specimen to make sure that there's no bacteria growing. And once I kind of get the physical done and the initial history, then that's when I start to institute therapy from day one. Ideally, IC is described as having the issue for more than 6 weeks. By the time somebody comes to see you, they've been dealing with it for a hot minute. So I tend to approach things a little bit differently. In my practice, we're a little bit more naturopathic than probably run-of-the-mill urologist or even urogynecologist. So I approach things with a big supplement program because I'm aiming to treat inflammation. So I will use things such as twice daily fish oil to help with inflammation. I like, we have a product that's called Mariva, which is essentially turmeric and curcumin capsules.
Okay.
Those actually have really high level of COX-2 activity, which is, if there's old medications like Celebrex, or other anti-inflammatories that were on the market for a long time that caused other problems. But the curcumin and turmeric doesn't cause ulcerations of the gut and things like that. And you can take it continually day by day to kind of dampen the inflammation that's happening in your bladder. And then the third supplement that I like people to use is called hyaluronic acid. So a lot of people are really familiar with that. It's in a lot of facial products.
Yeah.
They're supposed to decrease inflammation around zits and those kind of things. It's really used in orthopedics quite a bit. So they'll inject it into really arthritic joints that are inflamed. And where you hear about it the most in IC is that there are studies out of Europe where they were actually using the liquid form of the acid to instill it into the bladder. What I've found is that it's hard to get somebody to jump on board with that out the gate.
Yeah.
So I found an oral version that actually has bioavailability. So if you take it by mouth, you'll actually get relief. It gets processed through your kidneys and whatnot. You'll get relief in your bladder if you take it every day.
Wow.
So that's kind of like the anti-inflammatory approach to treating it. And that there's a couple of different thought processes as to what the etiology is of interstitial cystitis. And so our bladders are lined with this protein layer. They're called GAG proteins. And what happens is you get little cracks in the GAG protein, and the urine gets down into the detrusor muscle or the bladder muscle, and the potassium is there, then burns the bladder muscle and triggers what are called C fibers, which are the pain receptor fibers, and just send them crazy. They just go crazy and they start sending all these signals to your brain. So the anti-inflammatory aspect of that is to try to decrease some of that. But then one of the other things that also happens is you get this really kind of allergy response where you get a lot of mast cell degranulation, which are essentially those are the same things that make your nose congested if you have hay fever or one of those type things. Mm-hmm. So everything gets really congested and irritated. So that happens in the bladder too when you get the breakdown in the protein, that it stimulates the mast cells to do that. So in order to attack that, I'll use things over the counter such as Benadryl every day, like in the evening, or even hydroxyzine, which is another antihistamine. If they're a little bit too sedating for some people, like if they have to be at work and they just can't be, they don't want to be falling asleep and those kind of things. Even Zyrtec could potentially be a benefit. It's not really well studied using anything other than the hydroxyzine, but the biologic plausibility is there that it could actually be beneficial. And what's the harm? It makes you a little bit sleepy. Okay, most people can tolerate that.
Right.
So that's like where I start, and then from there I'll ramp up therapy. Primarily what you'll see if you go to an academic center is they'll use things such as tricyclic antidepressants, not because you're depressed, but mostly because those have been shown to decrease the messaging that happens through those neurons from your bladder to your brain. So it can actually dampen the pain response. The downside of those, it can kill your libido. So that's not a good thing. It makes people really sedated. So I tend to use that as like a second line or even third line. Other people will use what's called pentosan polysulfate or Elmeron. That is actually the only FDA approved drug for interstitial cystitis. The bad part about it is that it doesn't really work that well. It works about 50 to 60% of the time, and it takes a long time to work. It takes upwards of 6 months before you have any relief.
Wow.
And the side effect profile is pretty miserable for most people: diarrhea, GI upset. And then lately they've started to put out data that it could affect your eyes and your vision.
Yeah, I just read about that.
Yeah. So for me, like, I can't even tell you the last time I wrote that. Too much going on there to make me comfortable doing that.
That's actually very relieving. That's usually the first line of defense for a lot of doctors, is to write a script. So I know that for me, that was the first thing that was written, and I never took it.
Yeah.
I was like scared once I read about it.
Understandable.
Yeah, but I have tried the amitriptyline, which is what you were just talking about, mm-hmm. which I take such a low dosage of it, and I don't ever want to increase it. It has given me some relief, but I do like that you really have a more natural approach, because I think it's lost. It's so forgotten about, and it's really, that's what's available to us. We should use it, not always go straight to medicine. So I really appreciate kind of what you're doing. And I think it's a new way of thinking about it.
Yeah. And based on that too, and they probably gave you the same guidance, that they probably gave you a packet that had like a eat this, not that guide.
Yeah.
And that I hand that out like candy. I think is really helpful. The key for me though is if I tell people, hey, don't eat any of this stuff, what are you supposed to eat?
Right.
It's almost everything that's good is chocolate, mint, citrus fruit, sugar replacements. Any of those things in theory could stimulate a flare, but it doesn't. Not everyone's trigger is the same.
Right.
So for me, it comes down to go through here. Most of the time people know, hey, if I eat caffeine or drink caffeine, it really sets me off. Okay. So you've picked up on the triggers. So go through the list. If there's something on there that you just were not aware could be a trigger, dial it back, see what happens. If it doesn't make a hill of beans a difference,
right.
keep eating it.
Yeah, that's good advice. What's so frustrating for a lot of people, and I see this on a lot of support groups, is they just don't know what to eat. And it makes me feel bad because I've been plant-based, gluten-free, dairy-free for 8 years now. Mm-hmm. So for me, it was a very easy thing. Okay, I got to cut out some spicy, some citrus. All right, I'll work around it. But also, I can have citrus one day and be fine, and then eat it the next day and not be fine. So it's just so random, honestly. So it's really hard to just tell someone, hey, you can't eat any of this anymore, because that's not necessarily the right approach. Yeah. It may not affect you.
Correct. Yeah. And I've had other people that feel better if they eat more of like a ketogenic diet, where they get rid of the simple sugars. I'm not against that. My thought is, if it works for you, go for it.
Right.
If it doesn't, then enjoy the carbs, because I do. Yes. So, there's that too. And some of that data is coming from thyroid disease, where you have autoimmune processes that ramp up certain antibodies that attack the thyroid. So we're trying to extrapolate that data to, the bladder and chronic inflammation of the bladder. So in theory, it could be very helpful. And there's really no harm in adjusting your nutrition unless you're already super limited. So that's kind of right where we start baseline. And then there are procedural things you can do. The one that I tend to do the most, because I've had good results from that, and it kind of gives me another opportunity to check to make sure there's nothing structurally or visibly wrong with the bladder, is that I'll do what's called a bladder hydrodistension, which is I take people to the surgical suite for that, because I like them to be under anesthesia. I don't want them to feel that, so it would be pretty miserable.
Yeah.
Yeah. And so what that involves is we put a very, very small camera into the bladder, and we fill your bladder up to 80 centimeters of water pressure, and you let it sit there for 4 minutes. And what you'll see is a couple of things. One is it puts the bladder on stretch. So when it does that, that interrupts those C fibers, or the pain fibers, so they can't really fire off the way they were before. So it's therapeutic, but it's also can be helpful in diagnosis, in that you can see certain types of ulcers. They're called Hunter ulcers. And if you see those, you can cauterize them, and people get quite a bit of pain relief. Other things you'll see is this chronic inflamed appearance. But I guess the best way to describe that would be, it just looks really red and angry. And if you sit there and watch long enough, these little like micro capillaries, blood vessels will pop and start raining. They call it a raining blood. And it looks pretty crazy. It's pretty neat to see. So you can Google it and look at some photos of that. But for me, like, I'll see that frequently. But then sometimes you go in there and you're like, I know this lady has interstitial cystitis, and you fill them up and their bladder looks pristine. So it's really difficult, because what you see and what you feel don't always match, but it doesn't mean it's not there.
Right. So what's the difference between a hydrodistension and a cystoscopy?
So a cystoscopy would be putting the camera in and just filling maybe 300 cc's of fluid to look around your bladder. And then hydrodistension is the same technique. So you put the camera in, you fill with the same fluid, but you distend further. So mechanically, the way it happens is you actually will raise the little fluid bag, 80 centimeters above the pubic bone. So that generates that 80 centimeters of water pressure. And then when the fluid quits running in, then you know you've hit that water pressure and you start the clot.
Gotcha. And then you use anesthesia for that, but you wouldn't for a cystoscopy. Is that correct?
Some people, so where I operate, I don't have an office cystoscopy set up. So I still take people under anesthesia just for quick cystos for, if I'm looking for IC, or even if they just had blood in their urine, they need to be evaluated. It's a lot easier to have somebody go through a procedure like that where you're putting a camera in the urethra. It's uncomfortable when there's some sort of anesthetic there.
Yeah.
Some people will use local anesthesia like lidocaine jelly in the office if they have the ability to do that. And I have done that before where I was working before. But yeah, I like to use anesthesia. I'd rather you be comfortable. It seems easy to me.
No, definitely. That's actually why I canceled my cystoscopy, because I wasn't going under for it. And I'm like, nah,
yeah,
I don't think I'm going to try that today. maybe another time. But yeah, so that's interesting. I always kind of wondered what a hydrogestension was and how that really differed. So that's really great information about kind of how you go about diagnosing, what are some of the possible treatments, and of course, some of the procedures out there. So now I kind of want to get into your sort of medical cannabis background and how that could possibly be an effective treatment, or at least relief of symptoms for those who have interstitial cystitis. So tell me a little bit about that.
Yeah. So Oklahoma has been a medical cannabis state. I think we're going on year 2 now. And once we flipped legal, I started doing a lot of reading about how can I utilize cannabis in my patients. And the more and more I found, I was trying to focus on just the pelvis in general. And there's not a ton of data out there, but there was a lot for people with neuromuscular disorders like multiple sclerosis, where they have spasticity issues with their muscles being really tight, or chronic inflammatory conditions like rheumatoid disease and things of that nature. And so I was like, okay, I think there's something here, because these processes aren't that different. We have muscle spasm, we have chronic inflammation. And then when you start to look at what's called the endocannabinoid system, you have 2 main receptors, the CB1 receptor, which is in pretty much your brain and your spinal cord, and then CB2 receptors, which are elsewhere in your body. This is an endogenous system that's built into our bodies to utilize. So why not try? And so the more and more and more that I dug, the more and more I found research that was starting to dabble in pelvic floor issues. So there was only one study that I found focused on interstitial cystitis in general using cannabis, and it was a study they did on rats. So essentially, they gave these rats a chemical that irritated their bladder to essentially give them interstitial cystitis. I know that sounds terrible. But so they get their bladders really inflamed, and then they would either feed them like an isolated CB2 or cannabinoid receptor 2 compound that would just hit that receptor. They gave them, or they would give them placebo, or they would give a third arm where they actually gave them like a full extract cannabis oil. And the way they measured the response, they had like how do they do this? It's interesting. Like they would stimulate the rat with things that would make it hurt, and it quit responding after they gave it both the CB2 and the full extract cannabis oil, and it quit responding faster with the cannabis oil on board. So it was actually decreasing the inflammation in the rat's bladder. So it was super interesting to me. Yeah. And then there's a ton of data out there. If you start on PubMed, cannabis and muscle spasm, there's a ton, because it's been used in Parkinson's disease and multiple sclerosis to relieve spasticity. So to me, it just made sense. And then with that, then it became this journey of trying to figure out what's the best way to utilize it and to apply it. And what I realized is there's a couple of general rules. One is go low and go slow. It's not a race. And the best part about cannabis that I like is that you cannot kill yourself with it. You can't. So your brainstem doesn't have receptors for cannabis that would affect your breathing or your heart rate. So, and I challenge anybody to go on the CDC or whatever government website you want to try to find deaths that were based purely on cannabis alone. They're not there. It's not there. Usually it's drug mixing or something else, you know? And so, like I said, it became this journey of trying to figure out the best way to apply it. And I realized everybody's a little bit different. So then it became, hey, you can smoke it, you can eat it, you can apply it topically. If you have made suppositories before, you can cook it out into coconut oil and freeze them and make vaginal suppositories. In Oklahoma, we actually have a couple of companies that have really potent full extract cannabis oil that they mix in mango butter and freeze. And the reason they do that is there's another group of compounds in cannabis called terpenes, and that's what makes it smelly. And so the terpenes also have a lot of medical benefits. So depending on the cultivar, I guess the street term would be strain, but we're trying to reframe and change the propaganda around cannabis as a cultivar or chemovar. Depending on the cultivar, they have different terpenes. So if you smell one, it may smell like black pepper. If you smell another one, it may smell like lavender, and so on and so forth. And so, for instance, the one that smells like black pepper is high in what's called beta-caryophyllene, which is a potent anti-inflammatory. Who knew, right? So you can leverage the intrinsic property or the personality of that specific plant to suit your need, which is, I don't know, there's not very much else out there in big pharma that I would say you could do that with, that you could kind of feel your way through it. And a big piece of this too is for people that are going to try cannabis to treat their pain, it's like Fruit Loops, follow your nose, because your nose knows what you need. Right? If you smell one today and you're like, man, this smells really good. It smells like citrus. Okay, great. So you try that. The next day you smell it and it smells like blue cheese. Not today, right? There's a reason. Your body's asking you for what it needs. And so, and that's like my own personal take on it. But I do feel that having had these discussions with patients after we issue their card and they come back, that I think there's truth there. I can't prove it yet. Hopefully someday we'll be able to, but I know that the terpenes are probably as important or even more important than the THC that's in the plant or the CBD profile that's in the plant. I think the terpenes are really where the magic happens. Yeah. And then I tell my patients to journal everything. The time you took it, what the situation was, what the environment was like, what you liked and what you didn't like about the experience. That way, when you go back to your dispensary and you're meeting with the bud tender or whatever they call it in your state, that's what we call them here. You meet with your bud tender. Hopefully, they're educated enough to know that you're not there to just get blasted, that you're actually looking for help, that they can help you find things that fit the profile of what you need. So if something was a little bit too sedating and you can't use it during the day, to me, that says they need to back down on the myrcene, which is another terpene. So you go and you can find the testing report and say, okay, I need less myrcene, more beta-caryophyllene, and more, citrulline or whatever. So it tends to be mood elevating. And so by doing that, you're now able to like really hone in on what your particular body needs in that moment. And so the closer you get to the full plant, the more options you have. And there's scientific backing for that as well. They call it the entourage effect. So when it comes to what you're going to use, I tell people, ideally in the perfect world, using the plant in its raw form would be the best way to leverage the plant in its entirety. But that would require either smoking it or juicing it, right?
That's interesting.
So obviously inhaling cannabis in theory could cause issues with your lungs if you have reactive airway disease. We don't really know if there's a tie with cancer yet. We know that it can actually fight lung cancers and things like that. But there's just not enough data to know what the long-term scope of inhaled cannabis is going to look like. But what I tell people, the closer you get to the whole plant, the better effect you're going to have. Not everybody can do that or have access to that. So then you start getting into things like distillates or full extract oil. So when you start doing these concentrates, full extract cannabis oil means that it has the THC in it, all the cannabinoids, CBD, CBG, there's a bunch of CB everythings. And then it has all the terpenes too, and the flavonoids. So you're kind of recreating the plant in an extract. They tend to be a little thick. It's like almost looks like tar. So a lot of the dispensaries around here, they have little like self-applicating pens, and you literally would utilize about the size of a rice grain because it's so potent. And people usually put it on a cracker and eat it so they don't have to taste it. And then from there, you get things like your vape pens, which are usually a distillate. And sometimes they'll try to fancy it up and add some of the terpenes back in. But what we know is that they just don't work as well as the full plant. The chemistry just doesn't happen the same way.
Right.
So that's like the inhaled side of things. Now, edibles, gummy bears, cookies, crackers, I mean, if you can bake it, they can make it, And so why I like those for some people is that it gives you a longer duration of action. So, for instance, anything you smoke, inhale, tincture under the tongue, 15 minutes onset on average. It'll last you 2.5 hours maybe. Anything that you ingest that goes through your liver, because it's a bypass to your liver, you're looking at 45 minutes usually till you get onset of action, and it'll stick around 4 to 6 hours. And so it gives you kind of a longer duration of the inflammation control. And a lot of people can get away with microdosing that way, so that they don't have any of the psychotropic effect. It's not like they're high, but it's just enough to mitigate their discomfort.
That's interesting, because I've always kind of been afraid of the term edibles because of that whole duration. Sometimes you just can't, you don't want to be under that sort of psychoactive profile for that long. But I guess, microdosing would be a great way to, be able to do that while you can still sort of lead a normal life and work and, drive your car, and you don't have to worry about kind of that effect that you would get from eating like a full-on, brownie or something like that.
Right. And another thing to keep in your pocket. So say you're new to utilizing cannabis edibles and you're not wanting to smoke anything. If you keep a bottle of CBD handy, CBD will counteract the psychotropic effect of the THC without snuffing out the medical action. So if I have a patient that's going to try it, I make sure that they go and pick up CBD so you can dose it up. It'll bring you back down.
Yes.
So that's a nice little trick. That's kind of, I think edibles can be pretty powerful. But like you said, a lot of people are a little bit nervous to delve into that because they don't want to be kind of inebriated for 4 to 6 hours in the middle of their day.
Right.
And then you have your topicals. A lot of people use those for their back or their knee or whatnot. But you can look at a topical the same way as you look at it like a vaginal suppository. It's the same way. So anything that's applied to the skin and is absorbed has no psychotropic effect at all.
Okay. I always wondered about that because I do have a lot of, like joint pain and things like that. But I was always nervous. I'm like, is this going to get absorbed? Am I going to get, a really intense effect from this? It's always kind of hard to find information on that. So that's good to get the clarification there, because I think a lot of people, wonder about that, because there's also like the CBD topical, which obviously isn't going to give you that psychoactive profile. So kind of, I guess, how do those differ then?
CBD and the full cannabis plant.
Yeah, as a topical.
Yeah, so CBD and THC are different in that I consider the CBD to be kind of the medical actor there, but the THC is like a PA system that just amplifies the effect. So it goes back to the thought of the entourage effect, where you're getting closer to full plant. So if there's THC in it, usually there's CBD in there as well. And topically, it's a little bit tricky depending on where you live and what they're making. You want to make sure they have some sort of carrier molecule in there, because it may not absorb at all.
Right. Okay.
You're applying a fat, because usually they pull it out into avocado oil or spearmint oil or something like that, and you're applying it to your skin, which is a fat bilayer, and fat doesn't mix with fat. So a lot of places will use stuff like MSM or aloe as a carrier molecule to kind of help it penetrate the skin a little bit deeper. Yeah. But yeah, the CBD in general doesn't have any psychotropic effect at all. The problem is it becomes very cost inefficient. CBD is expensive. So if you get just a straight CBD isolate, they have to extract that out through the machine multiple times to get to the end product. So just based on the actual factory time and effort that goes into making it, it's more expensive. And not only that, you have to use a lot more of it to get the same effect. So that's why most people, if they say CBD didn't work, it's one of two things. Either they were taking an isolate instead of a full spectrum CBD, meaning it still had some of the terpenes, because you can get terpenes in a CBD hemp plant too. They were taking an isolate was just the CBD, so you're getting very minimal effect, or they're not taking enough.
Yeah, and like you said, with the not taking like the broad spectrum form, where you would get some of those other things like CBG and CBC, which have other sort of antibacterial, antimicrobial effects. So lots of great information. A lot of it can be a little confusing, so I appreciate you sort of clarifying the difference there and kind of shedding light about medical cannabis, because I know it's still sort of a controversial topic, but I think it can be a really great option for those who are dealing with interstitial cystitis and, of course, any sort of chronic pain and inflammatory disease. It can be really beneficial.
One other thing I would touch on as an option that's kind of new in what we're doing, I would encourage you to Google exosome therapy, which is like one step removed from stem cell therapy. So in our office, we're starting to do bladder installations with stem cell, essentially, to try to allow your body to absorb those exosomes and heal itself. So that's kind of cool and cutting edge stuff too.
Yeah, very innovative. That's awesome. That's great to know that there are some new types of treatments coming out. And of course, the continuation of research is so crucial for this disease. So I want to thank you so much for being on the show today. I really appreciate your time.
Yeah, absolutely. Thanks for having me on.
Yeah, absolutely. And I want to thank my audience for taking the time to listen to the Bladder Battle Podcast, special series I See in the Dark. Make sure you subscribe if you're listening on YouTube, or leave a rating or review on Spotify, Apple, or Google Podcasts. And stay tuned for the next episode right here on the Bladder Battle Podcast.